and all godfathers, I would say, like Dr. Rai Sahab, was my just like our mentor. Uh, so uh, let me begin with a current presentation in circulation research that shows that atrial fibrillation is a 21st century cardiovascular epidemic. And so many conditions are linked with it, right from the top, stroke to venous thromboembolism. So uh, before I really go to my talk, I would uh, pay my tributes to all those people in our healthcare community who have lost their life in India and abroad. And I have particularly put picture of Prabhatji, who was so lovely to us. So uh, now atrial fibrillation is a menace. I would say that we are facing the crisis. It's a real epidemic, and around like almost like 40, 45, 46 million cases across the world. We do not have exact data from our own country because we never believe in data collection. I would always request that we should develop this habit of this. Uh, Gentleman Gregory Lip with us in 2019 CSI meeting, and uh, everybody is able to listen to me.
Yeah.
Hello. So this is very classical atrial fibrillation ECG, and the differential diagnosis can be multifocal atrial tachycardia or atrial flutter. Uh, uh, 3 ECG I would like you to address. This is a ECG of atrial fibrillation, an accessory pathway which is deadly, and we should cardiovert. Secondly, again, there's a ECG of 85-year-old male, wherein requirement is anticoagulant. Currently, newer anticoagulants are very well there. This is another ECG of atrial fibrillation with complete heart block. This is another situation which we come across in our practice, daily practice, and we have to be very, very careful in using drugs which are blocking the AV node in case of atrial fibrillation, because ultimately you come down to this situation. I've been given a difficult task of telling that do all patients need to be treated? I would say yes, Dr. Virmani and Dr. N.K. Singh, yes, and other colleagues, because like why the paradigm has shifted from just the CHATS VAS score to many more things which I'll come across. So I'm presenting to you 66-year-old male, and is diabetic, and atrial fibrillation was detected by device, which is, and so my question is to you is, rather my submission to you all is, which one requires treatment? Less than 6 minutes of atrial fibrillation, 6 minutes to 23 hours, and more than 24 hours.
24 hours.
Yes, you are right. But then I just wanted to highlight this point because duration of atrial fibrillation is very important. So my agenda would be rapidly I'll go through the global and Indian scenario. Do all atrial fibrillation require treatment, which is the agenda today? What do we understand? Insight and phenotypes. Guidelines are there, but they are not our lifelines. Tips and tricks of management, my vision and your thoughts. See what is happening. We are sitting on the volcano. The cases are increasing every day and day, and it is expected that in coming few years, 2-3 decades, we'll have a volcano which will just going to erupt with more than 50 or 60 million cases of atrial fibrillation. So we need to have, we have to be very, very cautious right from the beginning. and proactive in detecting and managing atrial fibrillation. So we know that, of course, India doesn't come in that group of which US has got the highest number of European countries have got, and like 1 out of 3 persons will definitely have atrial fibrillation. And by the age of 70, 80 years, almost 10% people will have atrial fibrillation. So this is a natural history of atrial fibrillation, which is fatal in the end. I mean, you can see that death is 1.5 to 3.5 folds. You know, the cognitive decline is a very important issue, that this is a disease of elderly, and you see that without stroke, atrial fibrillation can lead to dementia and cognitive decline. You know, a couple of Indian data, my own data, I'm a little selfish. In 2012, I had this this presentation at ESC 2012, and this showed that we had the rheumatic heart disease as the commonest, which is not true now. We have atrial fibrillation, we have hypertension as a commonest cause of atrial fibrillation, and in those time, you know, for even 40% were not on anticoagulant, out of which about 20% were having adequate INR. So some of the smaller study from our own country, not very lucrative, but then Indian Heart Journal published a Indian Heart Rhythm Society AF registry of about 1,500 patients. You can imagine such a big country and we are not having enough data to prove ourselves. And these are this thing in those days, only warfarin. See, the only warfarin was being used, not the NOACs. And you know, our average age is less than the Western country. The most lucrative one is Kerala AF registry, which has been widely acclaimed across the world. And this is like almost like less than 40% patient, even in CHAD-VASc4 score, CHAD-VASc4, they are on anticoagulant. This is a very sad situation. And if you see the biggest registry known as Garfield AF registry, globally, even globally, their situation is very bleak. You can see that even aspirin has got quite good number of patients in high CHAD-VASc are on aspirin only. India is worse. You know, you can see that, you know, we had hardly anything like NOACs on our patients, and most of the patient, 20% patient have no anticoagulant, and majority of patient by mistake or whatever or ignorance, we use aspirin, which is not justified. So yeah, so this is all known to everybody that non-Caucasians are more prone male sex, genetics, aging, apart from everything which doctors have mentioned, is while Dr. Vikas was talking, on Dr. Raj Shekharan was talking, almost everything can lead to atrial fibrillation. This is the classically, you know, atrial fibrillation can be paroxysmal, persistent, or and all the risk factor can lead to atrial fibrillation by virtue of attacking on the left atrium. That's very important, because left atrium, we are focusing on left atrium now totally, and we are trying to see what is happening. Now, if you see the last recent 2021 ACC, which I was attending from virtual from here only, and you see there what is known as atrial cardiomyopathy or atrial cardiopathy. This leads to atrial fibrillation, or even without atrial fibrillation, that can lead to ischemic stroke. And you know, they have beautifully given a biomarkers like ECG, laboratory like biomarkers, and imaging as a method to diagnose. This is extremely important for all of us to understand. Pre-terminal force in V1, This is very important, and this correlates very well with MRI findings. So you can see that, and of course the morphology of LA appendage, which can be a kind of precipitating factor for atrial fibrillation. Why I am giving you a background? Because everything is that LA. You focus on LA, like atrial fibrosis in control. You see that majority of embolic stroke would happen in those individuals who have got maximum amount of fibrosis. Even in atrial fibrillation, who do not have so much of fibrosis. So fibrosis in left atrium is the final answer, and there are intricate pathophysiology of lipid infiltrating into the myocardium, into the myocardial cells. And this is, of course, aggravated by pro-inflammatory markers and metabolic remodelings, and increasing the action potential, conduction slowing, and all those things, ultimately fibrosis. So what is important is we should catch the case in the very early electrical instability stage to reverse it. So reversal of atrial fibrillation is very much possible, but possible how? By virtue of catching the case very early. This is my focus of attention today. And like, once you have persistent, long-standing persistent, we will not be able to reverse the pathology. Something to know about the diagnosis of subclinical atrial fibrillation. This is extremely important, because if you do not pick up subclinical atrial fibrillation, we fail in our duty to do something for the patient. And that is extremely important to do. And anybody who has got more than 30 seconds of atrial fibrillation is labeled as atrial fibrillation. And there are many devices which has come in the market now, commercially being used. And one can do from simple pulse to blood pressure to oximeter to Apple Watch to smartphones, which are available. And this is very important, because ultimately we have to pick up cases very early. This is an example of how the sinus rhythm was there. After 7 days, somebody has atrial fibrillation, comes to emergency, and lead one shows atrial fibrillation with ST elevation. And there are how people thought that this is myocardial infarction. So this was atrial fibrillation with myocardial infarction. This is the crux of issue. Now we, apart from CHATS-FAS score and risk of embolic complication, we have to look into atrial fibrillation burden. And the more is the burden, the more are the chances of stroke, even in the lower level of CHATS-FAS score. So, these are all known to everybody. I would recommend that one should read that 2020 guidelines of European guidelines on atrial fibrillation, which is very good and very successful. I'm not going to waste time. Couple of things I will add this, that atrial fibrillation are not at all to be used. Somebody is using aspirin or a combination of aspirin and clopidogrel. This is to be disregarded. And like NOACs have taken over. NOACs are definitely better than vitamin K antagonists, except two conditions: the mechanical heart valve and moderate to severe mitral stenosis be used. And we have to, the crux of issue is this: that's management of atrial fibrillation includes confirmation of diagnosis. I told you how, why, and why do we want early diagnosis, and then characterize A by 4S: stroke risk by CHATS-FAS, symptom severity by ERA score system, severity of AF burden by duration, spontaneous termination. So what is the duration, what is the severity, how many AFs are coming in that time. That's extremely important. And substrate severity, that is the age, comorbidity, and other factors. Now, the treatment is these three classical example. They are anticoagulation to avoid stroke by doing CHATS-VAS score, and obviously we are having NOACs in front in favor of vitamin K antagonist now. It's very clear now. Better symptom control, and third is comorbidity, muscular dysfunction, important. We control coming in now. So what happened? Now there is a situation where we are depending more on rhythm control, because rhythm control cannot be compared with rate control. That's what the factor is. The concept is today. Now, cognitive decline, we were talking about even without stroke in atrial fibrillation, one can have cognitive decline. That is extremely important to understand. And this is how we manage the classical atrial fibrillation, and upstream therapy is extremely important. And so is the primary prevention, because primary prevention at a stage when we have only risk factor, some changes in left atrium. A gentleman who was presenting a case in ACC, he said that, look, I have got some changes in the LA, so I don't know what will happen to me, whether I'm going to have atrial fibrillation or not. So catheter ablation took over. It is not that catheter ablation is useless, but then we have to identify which group are going to be benefited most. This is a very important slide, because like as we go, as the amount of atrial fibrillation increase by monitoring, by various maneuvers, the chances of stroke goes on increasing. So this is very important. And like there is a risk of stroke on one side, and other side is burden of atrial fibrillation. Interesting study, again, increased stroke according to the burden of stroke, increasing burden of stroke, which came in 2018 JAMA. And AF and anticoagulation, I'm not going to go into detail because like time is I think I'm only about 3. But now we understand that we have to focus on other risk factor also, like BMI, like proteinuria, like EGFR. This is the recent 2020 guidelines: positive cardiac troponin, NT-proBNP, LA volume, and LA emptying time, LA appendage emptying time, which can easily be picked up by echocardiogram, and ABC, that is age, biomarker, and clinical history stored. So we have added a lot in our knowledge sequence. And these are the choice of NOACs now being used. All of them have fared very well. Post-operative atrial fibrillation, very important. This can be a cardiac surgery or non-cardiac surgery. This is very important, that post-operative atrial fibrillation, even paroxysmal, needs a lot of attention. Rate control, we know what are the drugs which are being used. And so I'm not going to go into the detail of it, because I'll be wasting your time and in the time slot which has been provided to me. Rhythm control. Now, what I mean today is even rhythm control by ablation is not the sine qua non. Everything is now not RFA. We have so many drugs, which I'll come to that point very soon. And one point I want to add, that cardioversion is an important issue today. If you are having a heart failure with atrial fibrillation, if you cardiovert and the person remains in sinus rhythm for many months to 1 year, the chances of his remaining in sinus rhythm is almost like 50% or so. So what I mean is, we should use cardioversion more and more, And one added point is that the paddles should be AP, anteroposterior, rather than the conventional which we do. And second thing is, which a recent paper which has come is, you can have two pairs of paddles and do a simultaneously shocking, and then you see the results are much better. So long-term rhythm control, amiodarone, dronedarone, flecainide, propafenone, and sotalol. These are 4 drugs. This is very important that flecainide and propafenone are available in our country. Dronedarone came in some years back, but then I don't know what is the status today. And failure ablation is the answer. Now, I spoke to you about the heart failure with atrial fibrillation and ablation. Post-op atrial fibrillation, I told you that if hemodynamically unstable, you cardiovert. Otherwise, there are drugs which can be of use. This is extremely important. This study will give an extremely important take-home for all of us, including me. In the leisure time, I read a lot on atrial fibrillation, and this is East AFNET 4 trial. This is a wonderful trial. Paulus Kutschow from Germany, he was the principal investigator, and you see what that says, that if you use atrial rhythm control strategy, I'm not telling RFA strategy. What I mean is, if you use atrial rhythm control strategy by drugs, you can get a remarkable benefit. And so much so that the principal investigator, he summarized the risk of severe cardiovascular complication patient with AF is highest in the first year, mind you. That is why all the trials failed, because they never concerned about anything. Any duration, they started giving drug. So here, the drugs were given in the first year, even in the first month, second month. So early therapy is the most beneficial, because what he concludes is that atrial damage will happen within few weeks of disease, mind you. So you are losing very precious time, all of us. So all physicians, all GPs, all the cardiologists understand that we have to hit hard, hit early. And that is why this trial, compared to other trials in past, did better. So my vision is that burden of atrial fibrillation needs to be defined and refined. Dynamic nature of atrial fibrillation. Today, atrial fibrillation doesn't require any treatment. Tomorrow it will require. So it's a dynamic process. So we have to keep an eye on that dynamicity. If you are not keeping an eye on that dynamic nature of the atrial fibrillation, you probably fail. And interplay between CHADS-VASc and AF burden. Earlier only CHADS-VASc, what CHADS-VASc? We have to take care into other factors into consideration, and the most important is AF burden. And factors such as biomarker, which I told you, and I showed you how important it is to ECG in lead V1. Anatomical variables suggesting of atrial myopathy are extremely important. And this is what I'm time and I'm pressing this point, that we have to have a risk assessment, not by virtue of only CHADS-VASc, but also by virtue of asymptomatic heart rate elevation beyond 24 hours. Even now, confusion is that even 6 minutes to 24 hours, should we consider anticoagulation? Yes, if there are huge risk markers, then there are trials which are coming, which will show the result that even in that short-term atrial fibrillation, we do require. So the answer was very clear, which our genius friend, Dr. Hem Shankar Bhai, already said that this is more than 24 hours. He's right, but then time is coming, then we could have 6 minutes to 23 hours as well. So I hope I've given the answer to the selectors, Dr. Virmani and Dr. N.K. Singh, that atrial fibrillation burden and update need of CHADS-VASc AF burden score is there. So soon, guidelines will soon change their mind by the scientific knowledge and literature which we're having, to this fact that we should change our mind to how much is there flexibility in using anticoagulation? What is the threshold of treating atrial fibrillation? These are the factors which are soon going to come up. So with that, I end my talk. Thank you very much. Any question, I would love to answer. Thank you.
Thank you, Dr. Ajay Sinha, for a wonderful talk.
Yeah.
Just one last query. Can you first of all stop sharing your slides? Please stop sharing your slides. Then just one comment, last comment from you,
Yeah.
because we're already in very short of time. I was reading a paper 2 days back where the role of ivermectin was discussed, and it wrote that ivermectin can lead to atrial fibrillation, and it is also the treatment of atrial fibrillation. So can you give some clarity on that point?
I would love to, because recently I've been going through various literature, most current ones, and in fact I attended all the session on atrial fibrillation at ACC 21. Nowhere I could find this fact, and scientifically also I don't see ivermectin can be a choice